Bom, pessoal, bom dia a todos. Hoje teremos aqui a participação com o pessoal da Universidade de South Carolina. Eu agradeço muito essa oportunidade. E por questão dos nossos convidados, daqui para frente, vamos trocar aqui o nosso idioma da reunião para inglês, tudo bem? So, good morning, everyone. Welcome to the Surgical Optics meeting. I'd like to thank once again the participation of the University of South Carolina, here represented by Dr. George Waring and Dr. Raphael Penatti, and soon enough, Dr. Fábio Marujo as well. So we'll start our meeting with the discussion of published paper, and this will be presented by Gabriel Gatti, our fellow.
Hi, my name is Gabriel Gatti. I'm fellow in Escola Paulista Surgical Optics Service. And today I'm going to talk about this article, The Incidence of Intraoperative and Early Postoperative Adverse Events in a Large Cohort of Consecutive Refractive Lens Exchange Procedures, published in the American Journal of Ophthalmology last year. This article was wrote by this group of the University of California, and some authors declared that they were consultor of Zeiss and Avedro. The purpose of this article is to evaluate the incidence of adverse events in patients who underwent refractive lens exchange. This is a retrospective case series study with surgeries between July 2014 and June 2016. These adverse events were extracted from the electronic database of particular clinics of United Kingdom and Ireland. In order to maximize the reporting of adverse events, this electronic database cannot be closed without the user first selecting if an adverse event had occurred or not. In this study were included 10,206 patients with a total of 18,689 eyes. The patients included in this study had either clear lens extraction in absence of cataract or mild lens change with corrected visual acuity not worse than 20/40. All patients were advised to return for 1 day, 1 week, 1 month, 3 months, 6 months, and 12 months postoperative examination. The mean follow-up of entire study group was 8.9 months, and the percentage of patients that attended a minimum of 3 months follow-up visit was 87%. In all surgeries, lens fragmentation, capsulohex, and corneal incisions were performed using a catalyst femtosecond laser, and a white star signature was used for emulsification. When the corneal astigmatism was between 0.5 and 1.5 diopters, incisions were placed on the steepest corneal meridian, or an intrastromal astigmatism keratotomy was performed with the femtosecond laser, and a toric IOL was used in patients with corneal astigmatism greater than 1.5 diopters. A multifocal IOL was used in 84% of eyes, and 15% of eyes had a monofocal IOL implanted. The most common types of multifocal lens were bifocal refractive lens, used in 41% of eyes, and the second most commonly implanted IOL were EDOF IOL, used in 29% of eyes. About the results, from a total of 18,689 eyes, 1,164 adverse events occurred, and these events occurred in 1,112 eyes of 1,039 patients. This results in a 6% incidence, or 1 event, for every 17 eyes. And serious adverse events occurred 171 times in 165 eyes of 151 patients. This results in an incidence of 0.9%, or 1 event for every 113 eyes. Here's a table with all adverse events found. And I would like to start by pointing that posterior capsular obfuscation was the most common adverse event, occurring in 748 eyes, 4% of incidents. In addition, I would like to highlight that the most common serious adverse event was cystoid macular edema and other macular complications like macular hole or macular membrane. Another factor I would like to highlight is the very low rates of severe adverse events, such as retinal detachment, posterior capsular tear, or endophthalmitis. All these less than 0.1% of incidence. In special, the retinal detachment rate that occurs in just 3 eyes, or 0.02% of incidence. About the refractive results, on the total eyes, we see that 81% achieved a spherical equivalent less than 0.5 diopter, and that 96% achieved a spherical equivalent less than 1.0 diopters. If you look only at eyes that had a vision 20/20 or better in the preoperative, 9 achieved 20/20 or better in binocular uncorrected distance visual acuity. And only 1.66% of the eyes lost 2 or more lines of corrected distance visual acuity, the main cause being posterior capsular obfuscation. About the refractive results in eyes with adverse events, we see that 74% achieved a spherical equivalent less than 0.5%. Less than 0.5 diopters, and that 91% achieved a spherical equivalent less than 1.0 diopters. We can see that 98% of the patients achieved a vision 20/40 or better in binocular uncorrected distance visual acuity. If you look only at eyes that had a vision 20/20 or better in the preoperative, 78% achieved 20/20 or better in binocular uncorrected distance visual. But just 48% achieved 20/20 in macular in monocular uncorrected distance visual acuity. About the refractive results in eyes with serious adverse events, we can see that 78% of the patients achieved a monocular vision 20/40 or better, and 94% of the patients achieved a vision 20/40 or better in binocular uncorrected distance visual acuity. If you look only at eyes that had a vision 20/20 or better in preoperative, just 66% achieved 20/20 or better correct distance visual monocular, and 68% achieved 20/20 or better in binocular and correct distance visual in postoperative. But remind that 94% achieved 20/40 or better. And for the last, the outcomes of the Cox proportional hazard model shows that of all variables, older age and surgical volumes were the only factors affecting the incidence of adverse events. We can see that surgeons performing high number of surgeries per week were less likely to have their patient develop an adverse event. And the conclusion is that in this study, the incidence was loss of sight-threatening adverse events and significant loss of correct distance visual acuity in elective refractive lens exchange surgery. About the discussion, I want to ask to our guest, Dr. George Warren, if in your routine, the complication rates are similar in refractive lens exchange and in cataract phacoemulsification. Second, which type of IOL is the most implanted in your routine? Here in the study, bifocal achieved almost a half of the case. And what's the opinion about the rates of adverse effects found in this study, in particular on retinal detachment? And here I want to show that these retinal detachment rates differ from those found in previous studies, these two studies were in the reference of this study, but the rates of retina detachment were higher in their two studies. Thank you.
Thank you,
I will
Gabriel.
return to the questions here of the discussion.
Sure.
Yeah.
Thank you, Gabriel, for your presentation. I think this article tries to report the incidence of adverse events on RLE, and well, it has a shorter period of follow-up, and that's mainly the reason why some of these rates they may differ. But I'd like to ask Dr. Waring if he would like to comment on this paper, and already introducing him formally. And once again, thank you for your participation. Dr. George Waring is the founder of Waring Vision Institute and has served as assistant professor of ophthalmology and director of refractive surgery at the Medical University of South Carolina, and also served previously as clinical assistant professor at Emory University. And he's a well-renowned and great surgeon that also leads an extensive research in cataract and refractive surgery. I thank you once again so much for sharing your time and knowledge with us, Dr. Waring. So please, if you'd like to comment.
Thank you, Felipe. And thank you all for the invitation to be here this morning with you. It gives me great pleasure. And we love the connection that we have with Unifesp and the Medical University of South Carolina and the Waring Vision Institute. This was a wonderful paper, and I commend the selection because the unique aspect of this is the sample size. And Dr. Schallhorn's group at Optical Express, he really has mastered the art of large data analysis, which is a different type of research, and we can learn a great deal from it in ways that we can't learn from normal sample sizes. And so, we've spoken at length with Dr. Schallhorn over the years about large data sets like this, and it requires a certain style of research that it does not apply to normal data sets. So this gives us keen insights into all kinds of things that we've wondered about over the years. And one of them is safety and efficacy of refractive lens exchange. The other thing that's interesting about this group is that refractive lens exchange is performed regularly at Optical Express as a primary means of refractive correction. So this is not something that is done in exceptional cases. This is not something that's done uncommonly. This is becoming their primary mode of vision correction. So this is something that they want to know about. And I thought you did the discussion. You did an excellent job, by the way. It was a high-level overview of a complex subject. But the questions you've set forth for me, unfortunately, I can't read because of my presbyopia. So there we go. Are the complications rates similar in RLE and cataract? In our experience, and we have not formally studied our internally this. But anecdotally, I feel that they're lower. And we're learning that more and more, even in cataract surgery. We're not waiting for the cataracts to become as ripe as we used to. And I'm sure that this is a worldwide phenomenon. And one of the reasons is because this is more and more of a vision correction procedure these days. So instead of putting the paradigm of putting off the risk as long as possible to minimize the 0.1% chance to 1% chance of having an adverse event, as shown by Schallhorn et al., we're looking at this as an opportunity to enjoy life longer with spectacle freedom, improved quality of vision, and what we're learning to be safety. here's a startling characteristic for a little brain coffee. Falls in the United States kill more people than prostate cancer or breast cancer every year. And 1/3 of falls are directly related to bifocal spectacles. So that's a crazy statistic, but it's true. So there are other safety and lifestyle aspects to this about restoring functional vision as well. So related to safety, over time, the denser the cataract, the more manifest zonular weakness becomes through aging disorders and genetic disorders, the higher the risk becomes with cataract surgery. And the converse is true as well. If we've addressed an aging lens or a dysfunctional lens earlier in life, it would stand to reason, I think, that the relative risk would go down. Also, pupil size, less time to have been on something like Flomax or even the need for it. And just all kinds of other things that affect the relative. When you have an issue with cataract surgery, it's usually related to something along these lines. So I think that's an interesting way to think about this. Not to say that refractive lens exchange is not without risk, as we've just found out, and like any surgical procedure. And then, of course, there are relative risks amongst the refractive lens exchange group. So which IOL is the most implanted in our routine? We're not as fortunate as Brazil to have access or readily to some of the advanced technologies. And currently in our practice, we have primarily performed a mix and match routine where we use the extended depth of focus Symphony lens primarily in the dominant eye and a PanOptix trifocal in the non-dominant eye. And this is, we customize this for each patient. So this is not a one-size-fits-all routine. We will do whatever is best optically for each eye, but we treat each eye like an individual person. And then we allow the brain to take advantage of playing on that to get the best of both worlds. We see it as two opportunities to optimize vision by optimizing each eye individually. Number three, what is my opinion about the rates of adverse effects found in this study, in particular in retinal detachment? I think that retinal detachment is one of the most obviously feared complications of refractive lens exchange. And what I'd like to see is and we may discuss this is the work from the ESCRS study groups with the incredible work of Beatrice Koschener, drilling into what really are the risks of retinal detachment and refractive lens exchange, and more importantly, who is at risk. And just to cut to the chase, it's males with an axial length of greater than 25 under the age of 55. And so this is the highest risk category. And this is where we really have to take pause when we are considering a refractive lens exchange in this group because the increased risk of retinal detachment. We generally do not perform refractive lens exchange in these groups, but there are certain circumstances where this may apply, particularly if there's lens opacification or if they're not a candidate for corneal refractive procedures and unable to wear contact lenses or glasses. And this does occur. If that's the case, we have them preoperatively evaluated and screened by retina. And then also at 1 month, we have them postoperatively evaluated and screened by retina as well.
Okay, thank you, Dr. George Warren. And I'd like to ask if you could start your presentation, please.
Well, again, thank you so much. I remember I think the last time we did this, we had the pleasure of being together live. And I can't remember the date, but it had to be 8 years ago when we were having beautiful debates with Dr. Arce about the relative contraindications of against the rule astigmatism and LASIK. And I just have such fabulous memories of my time visiting that incredible institution. As you know, I'm part Brazilian, and my wife was a product of that institution, as well as so many of our dear friends and respected colleagues and mentors, both in Brazil and around the world. So it gives me great pleasure to be here today. I want to acknowledge our fellow, Dr. Raphael Penatti, who has just been a dream to work with. You guys should be very proud of the work he's done. We're so lucky to have him here with us. It's just been great, and he's helped put this presentation together as well. So these are my disclosures. We will be reviewing a few of these today. And I want to take a broad view and look at the aging lens. We're not just going to talk about risk of refractive lens exchange. We want to talk about presbyopia in general. And this is kind of neat. There's essentially, in this year, there are over 4.2 billion presbyopic eyes worldwide. It's hard to imagine another physiologic aging change that we've characterized like this in the eye that we can say that has an incidence of 4.2 billion. That's a lot of people that potentially are looking for help. And I think there is a factor on this that if you look at Asia, one thing that we learned in developing new technologies years ago in Asia is that presbyopia becomes manifest much earlier in life. So I think that there is a predilection and depending on ethnicity for biomechanical difference and anatomic differences that really do bring this on to be manifest earlier in life. So the age-old question, friends, cornea or lens? Well, the cornea has historically had greater patient acceptance for vision correction procedures. It's thought of as being less invasive. It's performed in a laser suite, and typically it's less expensive. So this really, in general, has been the more common way that we address vision correction procedures. The internal crystalline lens addresses the source of the problem, however. When we do a lens replacement, it can improve visual quality, as you'll see. It's a permanent solution, and it can be therapeutic for things like narrow angles and even potentially Fuchs dystrophy if we have a eventual cataract surgery. So many of you may have heard of the term dysfunctional lens syndrome. This was an attempt to characterize the human crystalline lens and propose a grading scale to the different aspects of the aging human crystalline lens. And we've published on this through the years and have adopted this terminology in our practice. And the American Academy of Ophthalmology has gone on to also adopt this terminology as well. So here, this was actually now a recognized syndrome from the American Academy of Ophthalmology. Well, what is the dysfunctional lens syndrome? This is really just an attempt to characterize and standardize the aging changes of the human crystalline lens. So it's not sufficient to say, well, you have a pre-cataract, because that is dismissive in a way. It really implies that it's meaning premature, meaning we are not going to do anything about it because nothing's happened yet. And we really don't think that this is the right way to approach aging changes. Why? Because when we do that, and we may perform a corneal vision correction procedure with hyperopic LASIK to induce monovision for somebody who's looking for a surgical treatment, generally speaking, what we learned over the last 10 years to 15 years is that people will be back in your chair saying, my LASIK wear off within the next 5 years, which it didn't. It's primarily the internal lens continuing to age, and then you're performing a second surgery with additional aberrations in the cornea and additional cost to the patient. We went on to propose a stage to the syndrome. The first stage is presbyopia. The second stage is lens opacity. And the third stage is when the lens opacities have become so manifest that daily activities are not possible. And that's an indication and equivalent of cataract, which then now applies for insurance and Medicare reimbursement in the United States. Historically, we had taught that in the first stage, we would be performing more of a corneal-based procedure because the internal lens is still clear. But for the second and third stages, where now the lens has become opaque, relatively speaking, we may do a lens procedure. And that was sort of the early thinking, but our practice patterns have changed over the years. And this has been proposed in nice diagrams in the ophthalmic news over the years. And again, in an attempt to standardize this. And we've looked at this objectively, trying to understand with advanced diagnostics, how do we make these decisions? When do we perform a corneal-based procedure or a lens-based procedure? So utilizing a double pass wavefront, here's an example of what I call a stage 1/2 dysfunctional lens. That's a early onset presbyopia. And we're in our center, we're helping to work on 3 different drops for the treatment of presbyopia. So this might be a perfect opportunity from a pharmacologic intervention here. You still have a clear internal lens with an excellent retinal image quality, as you can see in the double pass wavefront and objective scatter index. Now, what happens if we age somewhat? Our presbyopia becomes more manifest. This is stage 1 as we've defined it, but the lens is relatively clear as evidenced by the point spread function. And again, historically, this is where we may think about a corneal-based procedure, not necessarily an internal lens, because the lens is still relatively clear. Now, if we have moderate or high hyperopia, then more and more we shift more towards an internal lens-based procedure, including latent hyperopia, which we actually view as a premature aged lens, as you'll hear more from our case presentation. Our second stage now, our internal lens is becoming more cloudy, but the patient's perfectly functional. But this is somewhere you can see this is starting to affect image quality. So in our mind, we would be doing our patients a disservice by performing a corneal-based procedure because we're leaving an optical scatter in the optical system. And not only that, but typically if this patient is hyperopic, this is going to regress quicker and you'll be performing another procedure soon. Now, if this patient is a high myope, conversely, then this applies to my opening comments with the wonderful paper that we reviewed. This is where we really have to take pause and look at risk factors for retinal detachment and where we would potentially defer to a corneal-based procedure or phakic ICL. This is also a wonderful indication, even though it's off-label in the United States over the age of 50. And here you can see the various stages and why it can make more sense to address another opportunity with a lens-based procedure, that is improving quality of vision. Over the years, we worked with eye tracing technology on their ray tracing to validate the dysfunctional lens index. Here in the center panel, you can see here's a patient who comes with stage 2 dysfunctional lens to get out of their reading glasses. And we're trying to make a determination, well, the external optics are wonderful, but this is an internal optical problem where there's internal scatter. And in this case, it's not just scatter. This really is higher order aberrations that this is measuring. And on the dysfunctional lens index, you can see it's over in the red. So here's where we would be thinking more about a lens-based procedure. So we like to think of this as an emerging field of refractive surgery and the surgical correction of presbyopia. That warrants a fellowship. And I mean, think about glaucoma for those of us that do surgical glaucoma, that typically you would do a fellowship in. Think of all the surgical treatments for glaucoma. Well, look at this. This is really not too different when we're talking about the options for presbyopia and what's emerging in the future. So here's some work that we've done in some pilot studies, trying to understand how we can objectively, in a controlled fashion, look at improvement of quality of vision alone with refractive lens exchange. On the left, we looked at densitometry And you can see relative to a healthy control group of young LASIK patients, we doubled the densitometry, meaning we halved it. So you decreased the densitometry metric, which is a surrogate for light scatter. It's based on a grayscale and as a surrogate for image quality relative to a LASIK control group. So then when we looked at the same group with the objective scatter index that I just showed you, also we halved the scatter relative, and this is something that we already knew, but it's never been shown objectively how we can improve image quality alone with refractive lens exchange, not uncorrected or best corrected acuity, just image quality relative to a healthy LASIK group. So this was a presbyopia management algorithm adopted from a book chapter we wrote a number of years ago, Manus Cornea textbook that we've adopted for our clinic. And it just helps standardize based on the different stages of the dysfunctional lens, how we are thinking about treating these patients now, and with all the future technologies in the pipeline, how we may be looking at these in the future. Again, this now is standardized in our institute so that we have an intake track based on the referral pattern or what the patient calls in on, how our staff can then triage our patients and work them up appropriately based on their presenting demographics and some of the information we may have available. So when we talk about refractive lens exchange, there are a number of advantages. This addresses presbyopia at the source. That's obvious. It improves image quality where lens opacities exist. We just showed you this. This obviates the need for future cataract surgery, and therefore this has become an extraordinarily attractive option for many people seeking vision correction in the age of 50 range. And this may be useful where corneal refractive procedures are not indicated. In fact, this has become one of the most popular LASIK enhancement procedures for people that had LASIK early in life in their first stage of ocular maturity, now that they've entered their second stage of ocular maturity. So that is presbyopia. So this patients may not benefit from further corneal refractive surgery, and that's not the problem. They have an internal aging problem. And one of the real, I think, lesser understood advantages is the ability to preserve or provide stereopsis, which we would be taking away from them if we were to provide the alternate solution of a blended vision approach with LASIK. Well, what about high myopic patients? Well, we want to look carefully at peripheral degenerations. We know that there's a higher risk of retinal detachment. We have a low threshold for retinal clearance, possible preoperative barrier lasers, and we look for the presence of a PVD. But these are patients that we will err towards laser vision correction on the cornea or implantable contact lenses, or if they're not a candidate, wherever possible. Well, what about high hyperopia considerations? We found this to be an extraordinarily useful procedure for high hyperopes, but as you know, nanophthalmos significantly increases the risk of complications. Therefore, very careful attention must be taken with this subgroup of patients as described in the literature. What are our IOLs of choice? Well, we've got all kinds of IOLs. We've already discussed this, and the future is very bright for some of the technologies in the pipeline. But this is part of the decision-making process. As we mentioned, we customize it to each patient. And as you've seen, we have advanced diagnostics that really are now focused in a digital exam of showing patients in patient-centric terms their aging changes, that they have two lenses in their eye, both are opportunities for correction, and we also tend to use lasers to fix both. So we just keep this very simple when we're talking about it. Well, you heard me mention stereopsis, and one of the reasons that we have really shifted over the years towards lens-based surgery for presbyopia is because the patient satisfaction seems higher, and we're setting out to formally study this. And in fact, Dr. Penatti is going to be involved in this study. But what we've learned is just that our happiest patients are our refractive lens exchange patients. our unhappiest patients are our monovision patients. They generally require more hand-holding, they require more time for neuroadaptation, and they require more enhancements. My mentor, Dan Dury, when I was a fellow, was working and helping with his AOS thesis. This is the American Ophthalmology Society, which he did on stereopsis in contact lenses. And we learned a great deal from this. This is a big contribution to the literature. What he showed essentially was that as low as 0.75 diopters of anisometropia results in a statistically significant drop in stereopsis. So what does that mean? Well, it means a lot. We all know what stereopsis means, but one of the things I think that we don't readily think of is the impact of stereopsis on the synergistic effect of binocularity for distance vision, intermediate vision, reading vision, and contrast sensitivity. And we believe that that has a direct correlation with patient satisfaction and how patients do overall. And as a result, we're looking, our aim in the surgical correction of presbyopia, wherever possible, is to restore or maintain stereopsis. And therefore, the only way to do this really is with lens refractive surgery. Now, this is not without risk, and we've discussed the risks in detail, so we have to carefully weigh the risks and the benefits. This is our current technique for refractive lens exchange, which we call femto pre-chop. This has been described and published in a number of textbook chapters. And this is our preferred technique with laser. And we'll show you a brief video. Let's see if this plays on our technique. So when we have the discussion with the patients, we will just show them a digital view cross-section of their eye, and we'll just explain that we have lasers now, and the lasers we can treat the external lens or the internal lens. We'll explain that their eye is like a camera or a pair of binoculars. The eye needs to be in focus, and we want the lens clear to have a good picture. We explain that this takes about the same amount of time for a lens procedure, whether done with laser, or a LASIK procedure done with laser, and that now with laser, typically they're seeing well the next day, which is all true. We're careful to outline the different risks as well. And we also talk about the relative benefits, that with a lens procedure, with LASIK, we can provide a single focus point with each eye. With a lens procedure, we can provide multiple focus points with each eye. And also, we can prevent aging changes and therefore ensuing cataracts. And the future technology is very bright. This is a really exciting technology we're working on called refractive inject shape changing, which allows for customization of acrylic lenses with a femtosecond laser pre and post implantation. And before I summarize, I want to just talk about some of the other complications that were pointed out in the other text and the other paper. Posterior capsular opacification we do not believe is a complication, and we think that this is a disservice to the literature. We believe this is a normal healing change of a lens procedure, regardless of when it's done, and that is grossly underreported in the literature. We explain that lens procedures are really a three-step process. When we do this, that we perform the primary lens procedure that's fairly straightforward, as we just discussed. We allow the body to heal the lens in place, and in which case they will get some cells that grow over the lens that cause an opacity, and we will perform a laser capsulotomy when that occurs, if and when that occurs. And in doing so, that can cause the lens to shift forward or backwards slightly and bringing them slightly out of focus, in which case we may need to fine-tune their focus and with a laser vision correction procedure. Once this is all done, they tend to be set for good. And what am I doing? I'm setting expectations, because what we found is that although we can do all these wonderful things with lens procedures, we still can't control for effective lens position. And the earlier in life we do this, the more robust people heal, and the more likely their lens is to heal slightly out of focus. And I think that's what played out in some of the data that you saw with Optical Express in terms of their outcomes. And the way we manage this is by setting expectations for an all-inclusive 3-stage procedure. And we showed and have published in peer-reviewed literature the impact of early PCO on visual quality, and also the ability to restore vision quality and uncorrected vision with early PCO intervention. And when I say that, I mean waiting a minimum of at least 9 months if possible. So in summary, dysfunctional lens syndrome is a proposed way to characterize the aging lens. RLE should be considered for presbyopia treatment when safe. It treats the source of the problem, it can improve quality of vision, and it maintains stereopsis, and it also prevents cataracts. But careful risks and benefits should be considered. So, and I think John Marshall really summed it up best, friends, when he said, why should the cornea suffer for the crimes of the lens? Over, Gato.
Thank you, Dr. Warring. Great presentation. And I'd like to open to comments and questions if anyone would like to ask anything. I see that Brenner, Dr. Luis Brenner is online. It's a great pleasure to have you with us, Brenner. And he is performing a lot of lens procedures with refractive indications. So if you'd like to comment, Brenner, please, if you are part of all this. And well, Dr. Obidulio has sent me a question. Which eye do you usually operate first, and how? What is the time interval between one eye and the other?
We typically perform refractive lens surgery in the dominant eye first, and then 1 week later we do the non-dominant eye. However, like all things surgical, there are no hard and fast rules, and we customize that to the clients. So for example, for the true plano presbyope, where historically we would do monovision LASIK in one eye to maintain stereopsis, like we talked about, we don't do this much anymore. We'll do a refractive lens exchange in one eye, and that maintains distance stereopsis and provides reading vision as well, intermediate reading vision. So in doing so, and that's become our #1 treatment for plano presbyopes. And in doing so, we would then do the non-dominant eye only. So we really is a case-by-case basis, but this is something where for a routine patient, and the same applies for refractive cataract surgery, and we don't think it matters too much, but we found that we really want to nail the dominance because that's a requirement. You want to nail the distance. That's a requirement before you come nail the reading. And so we're looking for best quality of vision in the dominance, and that's why we feel the Symphony lens provides that with the extended depth of focus, active chromatic aberration control, spherical aberration control, and then a Panoptics for the broadest, for 3 focal points for the non-dominant for the reading. Also, the extended depth of focus lens has a broader sweet spot and is much more forgiving to residual refractive error due to ELP changes. The trifocal is much less tolerant, and therefore we found this to be another benefit too, because we really want to have the distance covered.
And also, which dominance test do you usually apply?
We use motor dominance. Our staff is trained to do this carefully, and we have prefabricated tools to do this, and everybody's trained in the standard operating procedure of checking dominance. So it's part of our standard. Everybody gets tested. If it's equivalent, then they'll perform optical dominance. Well, they'll introduce a plus 1.5 diopter lens over their best corrected state in a monocular fashion. and whichever eye is bothered less is their non-dominant eye. And that's been found to be more sensitive and more specific in our studies and FDA studies in determining dominance. There are about 10 to 15% of patients we believe that are near dominant, and we don't have a great test to determine those.
Thank you, Dr. Warren. Brenda, you had opened your audio. Oh, there you go.
Yeah. Hi, everybody. Thank you for the comments. First of all, thank you very much for the presentation, Dr. Warren. I have been with your father in Alicante. It was 2011. So I have met him and a very nice man.
Thank you.
But I'm going related to refractive lens exchange. I'm in Norway now, and we from Emir, we have started refractive lens exchange in 2010 almost. We have a long experience with refractive lens exchange. And from 2012, we start with trifocal IOLs. Our main focus is presbyopic patients, is presbyopic refractive lens exchange. I like your term of dysfunctional lens syndrome. I think it's very commercial from point of view, because when you want to say about pre-cataract, it doesn't work at all. Presbyopia, yes, it's a treatment for presbyopia. So just a concern about this, it's presbyopia, it's dysfunctional lens syndrome, it's the same thing. And yes, the presbyopic refractive lens exchange targets this kind of patients. In our routine, we differ a little bit about this as extend depth of focus lenses in the dominant eye. We don't do that. We do trifocal lenses in both eyes. We do bilateral simultaneous surgery, and with trifocal IOLs in both eyes. I'm going to present our results in the ESCARS meeting now in a virtual way. I'm going to present a free paper of our experience with 35,000 eyes operated with presbyopic refractive lens exchange. And I think that I have presented here in our meeting some of our results, and I think that things that must be very the most relevant things about refractive lens exchange are, first, biometry. I think that biometry is crucial for our results. So monitoring results, IOL power calculations, optimized constants, use of modern formulas it's a very important step to best results. I think that retreatment, I don't know what's your incidence of laser retreatments, but we are very aggressive in laser treatments. And sometimes we can do femto LASIK with plus 0.5 and just a little bit of astigmatism, 0.5, I think is our threshold for laser treatment. So everyone who wants to do presbyopic refractive lens exchange need to have assessment to learn excimer laser for fine-tuning. I think that's very important. We have reduced our laser treatments from 20% to 12% now in 2018. Due to some improvements in optimized constants and biometry formula. So I think that you can expect 15% of laser enhancements for those cases.
I agree. That's about we're probably about 10 to 15% ourselves. I'd say probably 10 to 12% right now. And we just, like I said, state it as an expectation so that they're planning on it. And I just wanted to emphasize Dr. Brenner's excellent point that those of us that have been doing this long enough, we've learned that as long as it's an expectation, and it's fine. And it really is just about controlling prophylactic lens position that we can't predict due to migration of PCO, really. But thank you again for pointing that out. We agree completely.
And we observed also that the polishing of the anterior, the posterior surface of anterior cups is very important, because when you get this kind of summer ring, you have some kind of migration, posterior migration of the lens, and you can expect some hyperopic shift. So I think that's some things related to the surgical techniques. First, we have discussed here before that the incision, you cannot take the incision for granted, because we observed here if the incision is a little bit broader than expected, you can induce trifoil. And we have cases here that the patient lost lines of corrected vision because of trifoil induction. Capsular X is very important, especially to do some kind of polish in the posterior rexis. And IOL position, I think that this is very important for the results. Take some considerations about these steps. I think it's very important for results. But again, thank you very much for your presentation. It was very, very interesting. Thank you very much.
Excellent comments. Thank you so much.
Yeah, yes, a question, George, please.
Yes, sure.
George, I have always been afraid of exchange a monofocal lens, which is the crystalline lens that doesn't work anymore, for diffractive optics regarding these photopsies. And how do you deal with these problems with your patients? Because for me, it's very hard to understand that it will be better. It's a good trade-off. I know they improve the near vision, for sure. But how do you deal with this trade-off? Losing one thing to gain another one.
Yeah, it's such an important question, and I'm just really appreciative of you bringing that up, because everybody, I think probably most people on this webinar have the same concern, and most anterior segment surgeons on the planet have this concern, and that's, I believe, one of the main barriers to adoption of this technology. And for my thinking on this is that it really is. It's a little different from refractive cataract surgery, where we now have access to lenses that we really truly believe in, so that in our practice, almost 2/3 of our refractive cataract patients get presbyopia correcting lenses. So we have a really, really large experience with this, and we believe in the technology. And but you say to yourself, well, that's easy because they have cataracts. So diffractive lenses relative to a cataract, that's much easier. But when we believe in it enough, where we start addressing not stage 3, but stage 2 dysfunctionality, and in many cases now we're doing stage 1 lenses with lens exchange, and believe it or not, as you're going to see, we're doing this in hyperopes instead of LASIK, particularly latent hyperopes, high hyperopes. So we're doing this much, much earlier in life than we ever thought that we would. And I just think once we do it enough, and we set the expectations is the key. And here's my language. You're going to see funny things around lights, Mr. Smith. You want to see those things because that's how you know your lens is working. This is your new lens. It's a starburst and it's a halo. And ironically, you want to see it. That's why you can read here, and out there for the first time in a long time. Your brain will filter it out, given enough time. They don't ever disappear, and you don't want them to, because you don't want your lens to stop working. Your lens will work. This lens will work for the rest of your life, but it becomes much more tolerable. And guess what? If in the very rare chance that you don't like it, I can fix it. So that's the other part of this. You just have to have the confidence and the comfort level for an exchange if you need it. But I can't remember the last time that we've had to do a lens exchange, knock on wood, for dysphotopsia in our own patients. This has become much less common with the appropriate preoperative counseling. So it's a worthy consideration, but I think the more and more you adopt this, and the more you counsel appropriately preoperatively, just like with an enhancement, it's the same thing, really.
Even for plano or for patients
Even, absolutely. It's amazing. Because they get different benefits that you would never thought of. Improvement in quality of vision, improvement in color, contrast. Stage 1 to 2 dysfunctional lenses, you've lost some color. You've lost contrast. Stage 2, it's easy. You definitely lost it. So you just work your way backwards in the chain. Get real comfortable with stage 2 to 3, then stage 2, then stage 1 to 2. And then when you're faced with a +7 hypero with a clear lens, you have to say, well, is there a solution for them? In the United States, we don't have hyperopic ICL. So that's our only treatment. Mm-hmm. And then when you see that works, it just, from a quality of vision standpoint, you kind of get the confidence to see that the optics are really that good as long as they're counseled appropriately. So that's a long-winded answer, but it's such an important question. I think it deserved the long-winded answer.
Yeah, thank you so much.
Thank you.
Thank you. We'll move on for the next presentation. It's going to be held by Dr. Raphael Penatti, which is also a fellow colleague from Brazil, and he has completed his fellowship in cataract and refractive surgery in Paraná Eye Hospital, and is now on his research fellowship in Warren Vision Institute. Thank you, Raphael, for your participation.
Good morning, everyone. Thank you very much for inviting me, especially Felipe for inviting me. It's really a pleasure for me to be here with you. I brought today a case that's not rarely seen here at Warren Vision Institute, and it has happened a month ago. This patient was 35 years old when she first came in clinic a year and a half ago for initial refractive evaluation. She had chief complaints of blurry near vision, headache, and ocular fatigue at the end of the day. And about her history, she had history of failing contact lenses trials in the past. At that moment, her uncorrected distance vision was 20/20 + 1 on her right eye, 20/15 - 1 left eye. Uncorrected near vision of J3 right eye, J9 left eye. Her manifest refraction at that time was +1.5 -1/4 at 120, correcting her vision to 20/15 - 1 right eye, and manifest refraction of +1.5 sphere, correcting her vision to 20/15 left eye. Her cycloplegic refraction was +3.5 -1/4 at 90, correcting her vision to 20/20 + 2, left eye +3.75. She is right eye dominant, and on her slit lamp examination, there were no remarkable abnormalities. Here on her right eye pentacam, it shows a low corneal astigmatism of 0.4 diopters with a slight inferior temporal steepening. And you can also see here her thinnest point of 552 microns, meeting the steepening dislocation. No anterior or posterior pathological elevations can be seen on her elevation maps. And here on her Bellingham-Broglie map, there are no altered signs, neither on the elevation maps nor on her pachymetric indexes. Left eye pentacam shows a low regular with the rule astigmatism of 0.6, slightly asymmetric with slight inferior steepening. IS is 0.6, and her thinnest point here is 542 microns. Normal, also with a slight temporal inferior dislocation of the thinnest point. No pathological signs on her elevation maps or on her Bellingham-Broglie maps can be seen. On her follow-up visit, she was submitted to a technique called hard fog. And in this technique, we use her manifest refraction and we add plus sphere lenses, and we try to see how much prescription she can accept without decreasing her distance vision. And in this test, on her right eye, she would accept plus 1.75 minus a quarter at 130. And on her left eye, plus 1.75. And it's important to show here that using her cycloplegic refraction on her dynamic eye would decrease her vision to 20/70 in both eyes. What do you think are our current options to treat this patient at this time?
And let me just butt in real quick. That is, she actually corrected to 20/20 with her cyclo with that plus 3.5. So that's that's has its own diagnosis. So I think that's where we want to start. So this is a typo here. This should be with cyclo to 20/20 for right eye and left eye with plus 3.5 and plus 3.75. So if we go back to the discussion, I think that's a good place to start. What's the diagnosis here?
So in summary, we have here a 35-year-old patient with a premature aging of the lens, with a high latent hyperopia, in chronic accommodation status, and ciliary muscle spasms all the time. And these are the sources of all symptoms. And after this first evaluation, we gave her two different options of contact lens correction. First option would be contact lenses on both of her eyes, and the second option only on her left eye. And we have to have in mind that in the past, she had contact lenses trial fails. And surgical options would be LASIK and refractive lens exchange. So it happened a year ago. We tended to be more conservative, and we gave her the contact lenses treatment options. She came back a year later after failing again her contact lenses trial with the same complaints of blurry near vision, headaches, ocular fatigue. She showed at this time similar uncorrected distance vision, but a decrease on her uncorrected near vision. At this time, she was J7, right eye, J11, left eye. At this time, she showed similar manifest and cyclo refractions and no changes on her slit lamp exam. We can now see her right eye pentacam, pretty similar to the images we saw on her first evaluation. We can see here left eye, pretty similar, a little higher astigmatism, but is still with the same characteristics. Regular, slightly asymmetric, slight inferior stiffening, but nothing that would worry us. She came the second time, decided to have a more effective correction instead of using contact lenses. And here are our current options. Corneal-based surgeries, we would be possible to have LASIK or PRK, and lens-based surgery, refractive lens exchange.
Raphael?
Yeah.
I don't know if I misunderstood, but she was not even wearing glasses.
Barely,
glasses, right?
Barely.
It's very complicated.
Yeah, it is very complicated. Yeah. But this patient here in the US, a very large number, they are referred patients from optometrists, and they are taking care of prescribing glasses, talking to these patients, and once they are referred to the ophthalmologist, usually they are seeking for surgery correction.
Yeah, and this is just real quick. This is a patient who had been seeking refractive surgery correction for a number of years. And she does wear glasses. She wears reading glasses for work. She's a local celebrity radio host who's the top, kind of the most famous radio host in the state, but has horrible fatigue even with her reading glasses that has worsened each year. So this is somebody who does require reading glasses early, and it's affecting her. She feels it's starting to affect her distance vision, but it's her fatigue complaints, and she's that she, even with contact lenses or glasses, that she can't get used to, and has been evaluated. Her initial evaluation was for refractive surgery correction for LASIK 3 years prior. We did contact lens trials to see how she would do with a blended monovision, which she did not tolerate.
So we know that corneal surgery is less invasive, less expensive, secure in young patients with this corneal profile. But we'd have to ask how long this treatment would last and how soon we would have to enhance this treatment to improve her distance and near vision. The second option, lens-based option, is more invasive. It has a higher cost. And although it's a permanent treatment, and it really treats the source of her problems. So we opted to have refractive lens exchange for her and talked exhaustively about pros and cons of this technique. And again, it treats the source of the problem. It does not induce high order aberration, and it's a permanent solution. And in the other hand, it's more costly, more invasive, and in young patients, this photopsia, as it's been asked before, it can be more bothersome in younger patients. Here we see her macular OCT with no major changes, no contraindications for the procedure. Here we can see her Scheimpflug image, clear lens, IOL master showing an axial length of 22.45. Again, low astigmatism, 0.47, no indication for toric lens. And here, as she's right eye dominant, we decided to have for her EDOF IOL, in this case, Symphony IOL. Left eye Scheimpflug image, again, clear lens, low astigmatism, 0.66, no need for toric lens. We chose for her non-dominant eye a panoptic lens to try to deliver a better near vision for this patient, axial length 22.14. This is a limbo relaxing incision nomogram. We tend to use this kind of nomogram more and more. It's very simple, very easy, very straightforward. You input the corneal astigmatism, age, what eye we are treating, astigmatism axis, and we have here the plan to have 2 incisions of 18 degrees length at 88 and at 268. But for now, we can only plan this limbo relaxing incision with temporal incisions. And I know in Brazil, we don't tend to use it a lot. We tend to sit at the top of the patient. Here, left eye LRI plan. Again, temporal incision, corneal astigmatism of 0.66. We also have 2 incisions, 27 degrees length at 92 and at 272. And here we have our patient's outcome 2 weeks after both eye surgeries. She shows better than 20/20 vision in both of her eyes, and she shows J1 plus reading vision with binocular vision. And she's extremely happy with our decision, and she's now an advocate for refractive lens exchange.
And excellent job, Raphael. And most importantly, her eye fatigue was resolved. And I think that was one of the things that she was looking for, to trying to achieve, was that benefit.
What was the patient age again, Raphael?
When she first came, she was 35. Now she's 37.
Okay.
Can I ask you, Raphael, her chief complaint before surgery was headache.
Blurry near
how is
vision.
her headache now?
Mm-hmm. Yes, she's feeling better. No headache anymore. No ocular complaints in the end of the day. No ocular fatigue in the end of the day.
Great job. Congrats.
Thank you.
Raphael, she did crack 2070 to 2020 on her cyclo vision, right?
Yeah.
Oh, cool.
Yeah, that was a typo. So that should have read 2020 for her cyclo, so that was a little confusing. But again, the diagnosis was latent hyperopia. And the thing is that we view latent hyperopia as a premature aged lens. And this is somebody where bifocals are going to become much more manifest earlier in life than they would for somebody without latent hyperopia. And furthermore, she's living in a state of chronic fatigue and chronic ciliary spasm, essentially, and just to see well for distance. So at first glance, that's why this case is so controversial. Here's somebody with a 35-year-old who presented with uncorrected vision of 2015 and J3. I mean, you might think this is crazy to do anything. And that's why it took us 2 years of working with her to determine what the best course of action was. And to make sure that we made her wait on at least 4 or 5 different occasions. We told her no. So this was not without extraordinary consideration, and she had also been to multiple other refractive surgeons through the years as well, looking for a solution. We tried monovision contact lenses, we tried everything, and it didn't work, but she could not handle the fatigue, and she could not handle the issues. But if she was absolutely living in a state of chronic spasm of accommodation to see distance, and she was every year growing out of it for her reading. And what happens, I mean, if you just think about what our options are, in our mind, she is not a candidate for LASIK because she will be back within a few years saying that it stopped working. And now she's with a hyperprolate cornea of 46 diopters, treating almost 4 diopters just to get her to distance and a 5.5 diopters to get her to read. So yes, we can do 5.5 diopter hyperopic treatments, but they tend to regress. You're inducing negative spherical aberration. You've limited your use of presbyopia correcting lenses in the future, and now you've performed you'll be doing another surgery when she outgrows it in a few years. And so these are interesting cases, but I think more and more an indication for real latent hyperopia is, or refractive lens exchanges, latent hyperopia and real latent hyperopia. We see this as a premature aged lens. And that's the teaching point on this case.
George, can I make a question?
Please. Yeah.
How long does your pre-op counseling takes? I mean, what is your approach or routine talk with your patient about the complications? We all know the very severe complications and minor complications, but how long does your counseling takes place? How long do you talk to the patients before surgery?
Thank you for asking. It's an important logistic question. We've really streamlined it over the years. So now it's the exact same amount of time as a LASIK counseling session, the exact same. So we do it in a refractive evaluation. There are different tracks, as I showed you in our talk, for lens versus cornea. But the discussion is the same amount of time as it is for LASIK. This patient, that does not apply. This patient, we counseled her the equivalent of 40 patients over 2 years. So when you get the ones that are not typical like this, she was over counseled to the extreme. It's extreme counseling. And so when you have extreme cases or subtle cases like this, obviously that's a different circumstance. But in general, we've been able to streamline it, much like our refractive cataract procedures.
Thank you, Dr. Warren. Thank you. We'll move on for our next case. Will be presented by Dr. Fábio Marujo. He has his medical degree and his residency and his fellowship here in Federal University of São Paulo, and he also conducted a ICL study, and will complement the techniques presented with his case presentation. Thank you once again, Marujo, for accepting our invitation, and please feel free to share your screen.
So thank you for the invitation. Great lesson so far. So I'm going to present a case from our service. It's a patient who had a Phakic IOL performed. I did a clinical study with star vision ICL. That's a patient from one of the patients from that study, actually. So it was a 24-year-old hairdresser, male patient who came to us seeking spectacle independence. He had high myopia and was a contact lens wearer, although he had suspended the contact lens 4 months before his first visit. And his ocular exam was, he showed us a spectacal corrected visual acuity of 20/20 on both eyes. His cycloplegic refraction was -11, minus 0.5 at 60 on the right eye, and minus 11.25 minus 0.5 at 120 on the left eye. His biomicroscopy was normal, and so was his IOP and his gonioscopy, and his fundoscopy only showed changes related to his high myopia. Here is his pentacam. You can see that he had a thin cornea with low astigmatism, only 0.5. And in his left eye, also a thin cornea, although not as thin, and slight skew deviation. So due to his high ametropia and his thin cornea, we chose to avoid corneal refractive surgery. And this patient was considered for phakic lens implantation. So here in Brazil, just a quick introduction, we have four phakic lenses available for us. So there is Artisan and Artiflex, who are two lenses that are iris fixated. There are two anterior chamber lenses. Artisan is not flexible, so here are the stitches, right? The suture in the superior part of the eye. Artiflex is flexible, so the incision is smaller. And there are two posterior chamber IOLs. The ICL, which was the one used, and at the time of the patient's first visit, it was the only one available in Brazil. And the iCrill, which is kind of new here, but it's quite similar to the ICL. And the ICL is a lens positioned in the sulcus, so in the posterior chamber, between the iris and the crystalline lens. There are many models actually, but these three are the models still available. So at the time of the patient's visit, the one available for us was the V4, which is a model without the aquaport, this central hole that allows the echoes flow through the center of the ICL. And this allows us not to perform an iridotomy while we must perform an iridotomy in the V4 model in order not to have to have an iris pupillary block. The ICL correction range is this, as I've shown here in this table. We can see that it's it's very wide, both for myopia and for ametropia. But here in Brazil, we do not have ICL available for hymetropia. And for myopia, it only comes from -6 to -18. So we performed some extra exams in order to see if the ICL was available option. Here's the specular microscopy from the patient. And the IOL master showed us an AL, an axial length of 28.03 millimeters in the right eye and 28.04 in the left eye. and the white-to-eye distance was 11.9 on both eyes. This is the OCT. Here in this study, the ACD, the interior chamber depth, was always measured by OCT, by Vicente from ZEISS, and it showed us a 3.41 millimeter ACD on the right eye and a 3.2 millimeter in the left eye. It's important for us that the ACD is always measured from the corneal endothelium and not the corneal epithelium. So we have to notice that. And if the ACD is larger than 2.8, we could perform a myopic ICL. So here's the calculations that it's the calculator from the Vision ICL website. And we just input the refraction, the ACD, and the white-to-eye, and it gives us the recommended ICL. So in this case was a 12.5 millimeter ICL with a dioptric power of -16 for the right eye and for the left eye. I do not have the video from that surgery, so here's a video from a commercial video from the EVO company. But just for the people who are not familiar with this technique to know what the surgery looks like. So we have two angled paracenteses, one in the inferior part of the eye and one in the superior part of the eye. This paracenteses are not going towards the center of the eye, but rather to the periphery, where we are going to have to put the footplate beneath the iris. We use 2% methylcellulose, and we do not use a lot of it, so we can still see the chains of the viscoelastic. The main incision is always made temporally. So in the US, where they sit temporal to the patient, it's a little bit easier, especially for the left eye. In order to insert the ICL, we have to do it slowly, because if we do it in a rush, the ICL tends not to unfold. And while we're doing it, we have to see if the ICL is well positioned by looking at the right leading footplate, that it has a little hole, a mark. So we add a little bit more of methylcellulose on top of the ICL in order to allow it to go easier, to position it easily beneath the iris. And we just tuck the footplates beneath the iris with this perpendicular fashion. We have to be careful not to touch either the crystalline lens, as it's a clear lens, nor the optical zone. Here it's showing that it's much harder to try to put the footplate beneath the iris if we try to do it on a parallel fashion. If we do it perpendicularly, it's much easier. And after all the 4 footplates are beneath the iris, we just we can either perform an automated IA or just irrigate in order to get the viscoelastic out. So I'm just going to proceed. Then we just hydrate the paracenteses and the main wound. Okay, so this patient in the 7th day post-operative, for the right eye, he had an uncorrected visual acuity of 20/25, a refraction of -0.25, -0.25 at 10, with a best corrected visual acuity of 20/15. And he was very happy with the results. Here is his OCT showing a vault of 470 microns. the distance, the vault is the distance between the posterior part of the lens, the ICL, and the anterior lens capsule. And in his left eye, he had an uncorrected visual acuity of 2020 with minus 0.5 diopters refraction, and a best corrected visual acuity of 2015. And a vault of 410 microns. So we can see that the patient was quite happy with the results, not needing glasses anymore. And 6 months after the procedure, the patient was still pretty stable. His refraction was now -1 with minus 0.75 at 15. So there was a small myopia, nothing considered to the one he had before. And his specular microscopy was pretty acceptable as well. Here is his vault, 419 microns. And in his left eye, the refraction was stable, minus 0.5, minus 0.25 at 150. With also acceptable specular microscopy. And his vault was 490 microns. So this patient followed up with us every year with pretty stable ocular examinations and refraction and vision. But 6 years post-operative, he came to us complaining of blurred vision on both eyes, and he said that his blurred vision was it started 6 months before this last visit, and his uncorrected visual acuity for the right eye was 20/80 with a refraction of -2, -0.75 at 55 degrees, but still having a best corrected visual acuity of 2015. His specular microscopy was still acceptable, and the vault was 470 microns. Here is a photo of the patient, so we can see that the ICL is well positioned, and there is a transparent lens and transparent ICL. And here is the left eye with an uncorrected visual acuity of 20/40 and a refraction of -1.75, -0.5 at 15 degrees. The best corrected visual acuity was 2015 as well, and his vault was 510 microns. Here is another patient of the patient, another photo of the patient, so we can see that the ICL is transparent. There is no cataract at this point, and we also had differential map on Pentacam. You can see that there is not much change in his exam, right? Neither for the right eye or for the left eye. And so as the patient had well-positioned ICL, no cataract and no change in the cornea, what must have changed was his axial length. So we had another IOL master performed, and we can see that there was a progression of almost 1.5 millimeters on both eyes. So at this point, we performed an oculizer as well, because our Pentacam was in maintenance in the last visit. So this is the oculizer for the right eye. You can see, of course, thin cornea, and as the astigmatism is low, it's 0.6. There is no really good bow tie, but we can see is a little bit of skew deviation and a little bit of inferior asymmetry. And in the left eye, also a thin cornea with this topography. So I'd like to open for discussions on how long should we wait for the progression to stop. So if the progression of the patient stops, how long should we consider that it would be okay for us to perform another surgery, if it would be okay, of course, and which surgery to perform. So a LASIK, a PRK, or even a refractive lens exchange. Since the patient's a high myope, maybe the refractive lens exchange wouldn't be a good idea, but since he already has an intraocular lens, it could be an option. Thank you.
Thank you, Marujo. Well, I'd like to ask Dr. Warren, what are his ideas about this case?
Marujo, that's an excellent case and great job presenting, like also with Dr. Penatti, who did a fabulous job too. You guys did really, really great. Can you please go back and share the format refractive maps so we can just evaluate their candidacy for laser vision correction here?
Sure.
Very good. And if you could enlarge that, and then I guess on the oculizer, you don't have a Bell and Ambrosio type
no, we don't.
indices. And then if you go back to the format again.
Oops, sorry.
Yep, that's great. And what is the pachymetry at the thinnest point? Or if you blow up your screen, if you enlarge your screen?
It's 523. I'm going to.
And it looks like fairly significant posterior and anterior elevation here, right?
Mm-hmm.
So this is I think this is a really, really neat case. I wish a little bit that we didn't tell everybody what was going on, because a lot of people might not pick up on that. And where these are really, really interesting are in what type of cases. This gets really interesting in patients that did undergo corneal refractive surgery 6 years ago. Now your differential broadens, right?
Mm-hmm.
So what's the concern there? In this type of patient with a myopic regression after a -9 correction, laser vision correction, what are you thinking about is ectasia, right?
Sure.
Very, very, very rarely would somebody be thinking about progressive axial myopia. Now, I had a fairly well-known cataract and refractive surgeon come visit our center earlier this year and had me evaluate them with that exact scenario. Previously -10, had LASIK 10 years ago, now with residual myopia, and with major concerns for ectasia, post-refractive ectasia. And we did not have pre-op axial lengths of any sort, and we diagnosed them with progressive axial myopia. And they did not have ectasia. So that's where that gets real interesting. So great case. This is a very real thing. I think it's poorly characterized and not well understood or appreciated. And ICL was a perfect solution for this patient. They were thrilled. They're probably still relatively thrilled, by the way. And this is somebody who I don't think there's really a right answer in terms of the timing. I mean, the first thing is, do they want a refractive surgical intervention or not? And if they're highly, highly motivated for it, I think given the anterior and posterior elevation here, I would stay away from LASIK. I would talk about an advanced surface ablation, which I think would be appropriate. And how old is this patient now, 6 years later?
It's 31.
31. So, so this is somebody who would likely benefit from having both eyes done. If we, assuming that both eyes look like reasonable PRK candidates, you can do them at the same time. And you just explained that likely you are going to progress over your lifetime. And you have a choice. We can treat you now and probably get another 6 years out of it and enjoy it. And then you're going to drift again. But eventually his myopia is going to start working for him, where if you were to do a second PRK enhancement at that time, you could just do a unilateral enhancement in his dominant eye and preserve his reading vision in his non-dominant eye. Alternatively, you let him get by with glasses if he feels like he needs them, or potentially contact lenses, which we're not big fans of, and let him age through it until he's presbyopic and then treat his dominant eye then. But I think he would benefit from having a PRK enhancement in both eyes now, just as though he was a LASIK patient who regressed. In which case you'd have really no hesitation, assuming there was no ectasia concerns, for a PRK enhancement bilaterally. Excellent case.
Thank you.
Excellent. Very nice case, Marujo, and great commentaries, Dr. Roaring. Well, we are a little bit ahead of time, so I'd like to thank once again for everyone's participation, and stay tuned for next week. We'll hold a meeting on confocal microscopy and have Professor Pedram Hamra with us. And it will surely be great again, as today our session was phenomenal with the participation of Dr. Waring and Raphael and Marujo. Thanks once again, everyone, and have a nice week and a nice weekend. And please join us whenever possible, Dr. Waring and US colleagues. Okay.
Thank you. Thanks, everybody. Great to see you. Thanks for the opportunity. Stay safe. We miss you, and we see you soon.
Thank you, everybody.
George, nice to see you here. Bye.
Thanks, everybody.
Thank you.